and we are going to briefly discuss bronchiolitis treatment. Bronchiolitis is a viral respiratory tract infection that is most common in young patients, typically less than 2 years old. Airway inflammation leads to excessive mucus and thick secretions that block airways, impair breathing, and make feeding difficult. Diagnosis is typically clinical, based on cough, wheezes, rales, and increased work of breathing in a child less than 2 years old, and does not typically include x-rays or labs. Because bronchiolitis is a disease of mucus and airway secretions and clearance, albuterol and racemic epinephrine do not help with treatment. All of those features are highlighted in the video that this QR code links to from the Children's Hospital of Philadelphia. Treating these patients begins with assessment, and assessment begins with the standard across-the-room pediatric assessment triangle assessment to evaluate the child's general appearance, work of breathing, and circulation to the skin. Next, it is important to expose the child and accurately count the respiratory rate for a full 60 seconds while assessing work of breathing. Then heart rate should be measured and oxygen saturation as well. More irritating and invasive vital signs like temperature and blood pressure should be saved for the end. Lastly, it is important to measure a naked weight to assess for dehydration as well as a capillary refill. A focused respiratory assessment should also be performed on these patients, including auscultation. After recognizing bronchiolitis, we begin with treatment. First, the severity of illness should be noted, such as mild, moderate, or severe, ideally using an objective score. Then, all patients should be suctioned and scored again. Many patients will be able to be discharged after simple suctioning. Patients with persistent hypoxia will require oxygen. Patients with increased work of breathing will require some respiratory support, and patients that are dehydrated or unable to tolerate oral intake will require hydration and glucose. As far as suctioning goes, there are many ways that it can be done. We're going to discuss a few. The first way is with the bulb suction. And this is the equipment that you need, and the procedure is really simple. You just squeeze a small amount of normal saline into the child's nose, squeeze the bulb, stick it in the nose, and release and empty the bulb, and repeat on the opposite side. This video shows just that very thing. A couple of drops of saline going into each nostril, which liquefies the mucus. The bulb suction goes in, suctions out the boogers are discarded on the side, and then the same thing is repeated in the opposite nair, as you can see as shown right here. The second way that suctioning can be performed is with the little sucker device, which is pictured here. Similarly, you just squeeze a small amount of normal saline into the child's nose. You stick the little sucker into the patient's nair after it has been placed to wall suction, and place a finger over the suction valve on the way out of the nair. You do it on the one side, then you repeat on the other side. And we have a video here demonstrating how it's done. Again, a couple drops of saline go into each nostril, and the little sucker device that's connected to wall suction goes into each nostril and removes the mucus from both sides of the nose, just as is pictured here. Sometimes including the opposite side can help with suctioning to help to clear out the ipsilateral side even better. The third way that we're going to discuss suctioning is shown here. That gives you a little bit more deep suctioning, and it's using a suction catheter. Suction catheters need to be chosen to be the appropriate size for the right patient. Less than 1 month old children typically use a 6 French catheter at 80 millimeters of mercury suction. 1 to 12 months of age typically would use an 8 French catheter at 80 millimeters of mercury suction, and 12 to 24 months old children will tend to use a 10 French catheter at 100 millimeters of mercury suction. Procedure-wise, it's very similar. Instill a small amount of saline into the child's nostrils. Insert the catheter into the patient's nostrils and place your finger over the suction valve on the way out of the nair to suction out the mucus that are there, and then repeat on the opposite side. This video here is demonstrating that on the one side. First, the nasal saline is going in both sides. Then the suction catheter goes in, suctions out the mucus. And then it is withdrawn. And then we jump over to the other side. Same thing, suction catheter goes in. The nostril is suction and it is withdrawn.
Now moving on to oxygenation and work of breathing.
For kids with bronchiolitis, our goal oxygen saturations are going to be greater than 90% with mildly increased or normal work of breathing. If the patient is having difficulty with oxygenation, oxygen can be added to maintain saturations of greater than 90%. If persistent, excessive, increased work of breathing is noted, then support can be escalated with high flow nasal cannula and then CPAP or BiPAP, and potentially endotracheal intubation, although endotracheal intubation is not commonly necessary with standard run-of-the-mill bronchiolitis. Just like most sicker children, patients with bronchiolitis, especially really sick kids with hypoxemia or increased work of breathing, can get dehydrated and hypoglycemic from poor oral intake. IV fluid boluses and maintenance IV fluids with dextrose, such as D5 half normal saline, can prevent and treat dehydration. Alternatively, enteral feeds through G tubes or NG tubes are great. Avoid oral feeds in children with respiratory distress or severe hypoxemia. Thanks for joining us today just to discuss briefly bronchiolitis. Reach out with any questions at the email address below and review the rest of the information that you can find on the website. Thank you.